Welcome to the RadOnc Smart Review Head and Neck Cancer series.
It is great to be back.
This is episode 31, Hypopharynx One Anatomy, Prognosis, and the Worst Actor Paradigm.
And today we are tackling the subsite that, frankly, earns its reputation as the absolute worst actor in head and neck oncology.
The worst actor. That's a pretty heavy title. I mean, you think about anaplastic thyroid or even nasopharynx, and they're tough. But hypopharynx, it's just in a different league, isn't it?
It really, really is. You could call it the widowmaker of head and neck cancer. It just combines all the worst biological traits you can imagine and puts them in one anatomical spot.
What do you mean by that?
Well, think about it. It presents late, it spreads early, and maybe worst of all, it hides submucosally. It's deceptive.
And what's the implication of all that? I mean, for us as clinicians.
The implication is that your default choices, the decisions you make before you even, open the planning system or really look at the scan in detail, they have to be aggressive from the get-go.
Okay, so this episode is going to be really foundational, and I want to set expectations for everyone listening right now. We are not going to be contouring a single structure today.
No, not at all.
We're not drawing CTVs or, debating dose gradients. We're going to save all that contouring stuff for the next episode.
Exactly.
What we're going to do today is hardwire 4 defaults. These are the 4 principles that are going to drive every single management decision you make later on.
That's the key. We have to build the mental framework first. If you don't really understand the behavior of the disease, if you don't respect this beast, you just can't draw the target volumes correctly. You'll undertreat.
And the patient will fail.
So
let's get these defaults on the table right now, just so everyone knows where we're headed. We'll unpack each one in a lot of detail, but let's just list them to kind of anchor the discussion. What are the 4 defaults we need to burn into our brains?
Okay, default number 1. Retropharyngeal nodes are on N. Yes. This is a huge, huge tripping point for residents who are used to treating the larynx. Unlike a glottic larynx cancer, the hypopharynx drains to the retropharyngeals. If you miss them, it's a geographic miss.
Got it. Hypopharynx equals retropharyngeals. Okay, default number 2.
Default number 2. Bilateral neck is on N.
Always.
Almost always. I mean, there's greater than 50% occult nodal involvement, even in a tiny T1 and 0 tumor. The lymphatics are just so rich, and the crossing patterns are so unpredictable, you can't gamble on treating just one side.
So no unilateral neck treatment. Got it. Default number 3.
Default number 3, inferior extent is on N. You must assume the disease goes lower than what you can see on that scope.
Right.
Submucosal spread, skip lesions, they're real, and they are notoriously difficult to see.
So we don't trust the bottom line we see on the scope. And, okay, finally, default number 4.
Default number 4 is prognosis reality. You have to plan, the failure risk is real, because it is.
How real?
We're talking about 25% of patients developing distant Mets in the first 2 years. That's despite successful local treatment. This is, hands down, the worst prognosis in all of head and neck.
Okay, those are the pillars. Retropharyngeals on, bilateral neck on, inferior extent on, and prognosis reality. We're going to drill these until they're just second nature. But let's anchor this with a case right away. We need some clinical context to hang these facts on.
Absolutely. Let's look at a classic presentation. I mean, this is the bread and butter of a busy head and neck clinic. We've got a 58-year-old man. He's referred to your clinic.
Okay.
And he's got a 40-pack year, smoking history, drinks 2 to 3 beers a day.
So a standard risk profile. And it's worth just pausing on that synergy there. The alcohol acts like a solvent for the carcinogens in the tobacco, so that combination,
yeah,
it's multiplicative. It's not just additive for hypopharynx risk.
Exactly right. That mucosa has just been bathed in carcinogens for decades. So he presents with progressive dysphagia over the last 6 weeks.
Yeah.
It started with solids, steak, bread, but now it's progressed to liquids. He even mentions he has to wash everything down with water.
That progression from solids to liquids is it's a classic sign for a mechanical obstruction.
It is. And the systemic toll is already there. He's lost 15 pounds.
And that weight loss is so key. It speaks to how severe the dysphagia is, but it also hints at cancer cachexia. It really changes how we think about his fitness for chemo down the line. What's the exam show?
On physical exam, you palpate a 2-centimeter firm left level 2 node. It's mobile, but it's distinct. So you proceed to flexible laryngoscopy. And there you see a mass that's arising from the left piriform sinus. And there's pooling of secretions.
Pooling secretions. That phrase is such a massive red flag in any exam note.
It just screams obstruction. The normal swallowing mechanism is blocked, so saliva is backing up like a clogged drain. It also makes the exam incredibly difficult.
I bet you can't see through the fluid.
Right. So the tumor appears to involve the medial and lateral walls of the pyriform. The arytenoid is mobile, and the true vocal cords are moving symmetrically. But the inferior extent, it's really hard to visualize because of those secretions. The scope suggests the tumor stops at the apex of the pyriform.
And I'm hearing stops in huge air quotes right now, because that is a trap we are definitely going to talk about later. Just because the scope hits a wall of tumor doesn't mean the cancer ends there.
Not all. So what about the imaging?
Yeah, let's see the scans.
CT, with contrast, shows a 3-centimeter hypopharyngeal mass. It's centered in the left piriform sinus, but there's extension toward the postcricoid region.
Okay.
There's a 2.5-centimeter left level 2 node with central necrosis, and a 1.2-centimeter left level 3 node. No right-sided adenopathy, and no obvious retropharyngeal nodes on the scan.
That central necrosis in the node, it usually points away from HPV and more toward the classic smoking-related squamous cell, which, Tim Kids' history, and the PET CT.
The PET CT shows FDG avidity in the primary and in those left neck nodes. No distant metastases.
And the biopsy.
Biopsy confirms moderately differentiated squamous cell carcinoma.
Okay, so the consult question is simple. What's your treatment recommendation? But before we answer that, let's imagine we're in an oral board exam. The examiner leans forward and asks, what are your default nodal volumes for this patient, and what is your first fear?
This is exactly where you need a script. You cannot stumble here. You have to be able to synthesize the case and your plan in under a minute and show real confidence and safety.
Right. And for everyone listening, I am going to perform this 60-second board script exactly as a resident should deliver it. Yeah. This is not casual conversation. It's a precise medical presentation. It covers everything. Demographics, staging, workup, the standard approach, and those critical defaults. Okay, here we go.
This is a 58-year-old man with a left piriform sinus squamous cell carcinoma, clinically T3N, 2BM0, stage 4A, by AJCC 8th edition. Workup includes CT and PET CT confirming localized disease. Dental evaluation and nutrition assessment are indicated given his dysphagia and weight loss. For a patient with locally advanced hypopharynx cancer and preserved laryngeal function, the standard approach is definitive concurrent chemoradiation with high-dose cisplatin, assuming he is medically fit. Organ preservation is reasonable based on EORTC 24891, though outcomes remain poor compared to other head and neck subsites. My default nodal coverage is bilateral levels 2 through 4 plus retropharyngeal nodes. I will add level 6 if there is postcricoid or cervical esophagus involvement, and level 5 if there is bulky upper neck disease. My first fear is underestimating the inferior extent of disease. Hypopharynx spreads submucosally, and what I see on scope may not reflect true tumor extent. I will carefully evaluate for skip lesions and esophageal extension on imaging. Late effects include pharyngeal stenosis, chronic aspiration, and hypothyroidism. I will counsel on PEG dependence rates and involve speech-language pathology and nutrition early.
That was excellent. I mean, that is the framework. I want the listener to just rewind that 10 seconds and memorize that flow. It hits every single critical point.
Like the staging.
The trial justification, the nodal defaults, that specific fear you have about the anatomy, and even the toxicity counseling. It's all there.
And notice I mentioned nutrition assessment right away in that first paragraph. Why is that so critical right up front?
Because of the weight loss. If he goes into treatment malnourished, he is not going to tolerate that cisplatin. He'll have treatment breaks.
Which are fatal in squamous cell.
Absolutely. So you're identifying a barrier to care malnutrition, and you're solving it up front. It shows you're thinking ahead.
Okay, now that we have that framework, let's unpack it. Let's build the knowledge that supports that 60-second speech. We have to start with the core clinical content, focusing on the anatomy, the map that matters.
Anatomy really is destiny here. I mean, understanding the geography of the hypopharynx explains exactly why this disease behaves so badly. It's not just memorizing muscles, it's about understanding the room the cancer is growing in.
Let's define the borders first. So where exactly is the hypopharynx?
Okay, so the hypopharynx sits posterior to the larynx and also lateral to it. Think of it like a sleeve that wraps around the back and the sides of the voice box.
Okay.
Its superior border is the hyoid bone specifically, the level of the pharyngoepiglottic fold. This is what separates it from the oropharynx above.
So above the hyoid, you're in the oropharynx. Below it, you're in the hypopharynx. What about the inferior border?
The inferior border is the inferior edge of the cricoid cartilage. This corresponds roughly to the C6 vertebral body.
And what happens right at that inferior border? This is probably the most dangerous real estate in the entire neck.
It really is. That's where it transitions into the cervical esophagus. And this is a critical concept. The hypopharynx and the cervical esophagus are continuous. There is no magic wall there.
No fascia, no sphincter.
Nothing that stops the tumor from spreading. The tumor does not respect the boundary between throat and esophagus.
So if a tumor is just pushing that lower border, it can so easily slide right down into the esophagus. And that changes your staging, your nodal drainage, your whole margin plan.
Everything.
Now, within the hypopharynx itself, we have 3 distinct subsites. I like to use the mnemonic, the 3 Ps.
The 3 Ps is a great way to organize this. Yeah, walk us through them. Let's visualize them for everybody listening.
Okay, the first P is the piriform sinus. This is the big one. It accounts for something like 85% of hypopharyngeal cancers.
85%. So just statistically, almost every hypopharynx case you see is going to be a piriform sinus tumor. If you hear hypopharynx, your brain should immediately think piriform until you're proven otherwise.
Exactly. So these are paired, they're funnel-shaped recesses lateral to the larynx. Just imagine 2 inverted pyramids, one on each side of the voice box. The piriform has a medial wall, which it shares with the areocataglottic fold in the larynx. It has a lateral wall, which is the thyroid cartilage and the thyrohyoid membrane. And then it has an apex that points down inferiorly toward the cricoid.
And that funnel shape is so key. Just think about gravity. When you swallow, food and saliva are funneled down through the piriform sinus into the esophagus. If there's a tumor there,
Gravity's pulling everything down.
it's pulling secretions and it's pulling tumor cells right down toward that apex. And that's why the apex is the absolute danger zone for inferior spread.
Okay. The second P is the posterior pharyngeal wall. This is the flat mucosal surface right behind the larynx, extending from the level of the hyoid down to the cricoid.
Right. Think of this as the back wall of the room. It lies directly on top of the prevertebral fascia.
Yeah, the third P.
The third P is the postcricoid area. This is the anterior wall of the hypopharynx. It's sort of draped over the back of the cricoid cartilage, going from the arytenoids down to the inferior border of the cricoid. It's the rarest subsite, maybe 5% of cases.
But it has some really unique features.
It really does. Very unique.
So let's talk about the personalities of these subsites. Their failure patterns. You said the piriform sinus is the most common. What's its failure personality?
The piriform sinus is just famous for its incredibly high nodal burden. It has a ridiculously rich lymphatic supply. Even a tiny T1 tumor one you can barely see has something like a 60% nodal involvement rate.
60%.
Yeah. And overall, nodal rates approach 75%.
Wow. That's massive.
Yeah.
That basically means you never treat a piriform sinus without treating the neck. It's
Right.
functionally impossible to have a safe piriform cancer.
You got it. And because that medial wall of the piriform is shared with the larynx, these tumors just love to invade the paraglottic space. That's why you always check for vocal cord fixation.
Right.
If that cord is fixed, it means the piriform tumor has invaded deep into the larynx, and that upgrades it to a T3.
Now, what about the posterior pharyngeal wall? What's its personality?
The posterior wall has a super high risk of retropharyngeal nodal involvement, and it makes sense, right? The lymphatic drainage goes straight up and back to that retropharyngeal space.
It's a midline structure, too.
It is, which means it also has a high risk of bilateral cervical drainage. And locally it's dangerous because it's sitting right on the prevertebral fascia. That fascia acts as a temporary barrier, but it's not a permanent one.
So if the tumor breaks through?
If a posterior wall tumor breaks through that fascia, it invades the prevertebral muscles. That immediately upstages the patient to T4B unresectable.
Wow. And finally, the postcricoid area. This one's the real outlier.
The postcricoid is fascinating. It's the only head and neck subsite that actually has a female predominance.
That is a classic board fact. Why is that?
Well, historically, it's been associated with iron deficiency anemia and Plummer-Vinson syndrome. Do you remember the triad for Plummer-Vinson?
Yeah. Dysphagia, iron deficiency anemia, and esophageal webs.
Correct. The theory is that chronic iron deficiency leads to mucosal atrophy and these web formations, which are precursor lesions. But from our perspective, from a radiation oncology perspective, the most important personality trait of the postcricoid is its location. It just extends right down into the cervical esophagus.
Which means it requires unique nodal coverage.
Specifically level 6. The paratracheal nodes, we're going to get to that in the defaults, but you absolutely have to associate postcricoid with level 6. If you treat a postcricoid tumor and forget the paratracheal nodes, you are leaving disease behind.
Okay, so here's the board hook for everyone listening. When the examiner says hypopharynx, Your brain should fire off these associations immediately. Pyriform equals nodes everywhere. Posterior wall equals RPLN and prevertebral fascia. Postcricoid equals female, iron deficiency, and goes inferior to level 6.
That's perfect. That's the map. Now let's move to the second core section, prognosis. We called this the worst actor paradigm. Why is the prognosis just so brutal compared to, say, the larynx?
It's not just about memorizing survival numbers. We have to understand the mechanism. And there are really 3 drivers of mortality here.
Driver 1 is late stage of diagnosis.
So why do they present so late?
Because the hypopharynx is a capacious space, it's roomy, it can accommodate a lot of tumor growth without causing early symptoms. You contrast this with the glottic larynx. Right.
In the glottic larynx, a tiny 2-millimeter tumor on the vocal cord causes hoarseness immediately. The patient runs to the doctor because their voice changed. We catch them at T1.
But in the hypopharynx?
In the hypopharynx, the tumor can grow to 3-4 centimeters. It can infiltrate muscle, it can send mets to the neck, and the patient feels absolutely nothing until it's big enough to block swallowing.
So it's a silent killer.
It is.
Okay.
By the time they have dysphagia or odynophagia, the tumor is often T3 or T4.
And the numbers back this up. I mean, greater than 80% of patients present with stage 3 or 4 disease, you almost never see an early hypopharynx.
Almost never. So driver 2 is the node-heavy biology. We touched on this, but let's really drill down. The hypopharynx has rich bilateral lymphatic drainage. Nodal involvement at presentation is 65 to 80%.
And that includes occult disease, right? Even clinically N0 patients with no palpable nodes and totally clean CT scans, have a greater than 50% risk of occult nodal disease. It's the highest occult rate in the head and neck, which is exactly why elective nodal irradiation is mandatory. You cannot just observe a hypopharyngeal neck, but it's worse than just regional nodes.
How so?
Hypopharynx has the highest rate of distant metastases of any head and neck subsite. We're talking about 25% of patients developing distant mets in the first 2 years.
That is just a staggering number. 1 in 4 patients will fail distantly, lungs, liver, bone, even if you perfectly control the disease in the neck.
Exactly. This is not a disease you can cure simply with better local control. You have to be thinking systemically. This is why we push so hard for chemotherapy in these patients. We're treating the micrometastases we can't see.
Okay, and driver 3.
Driver 3 is submucosal and skip spread.
What you see is not what you get.
Precisely. The mucosa might look totally normal on endoscopy. It could look pink and healthy. But that tumor can extend submucosally for centimeters beyond the visible edge. It travels in the lymphatics right underneath the lining.
And then you have the skip lesions.
Then you have skip lesions, these discontinuous foci of tumor. A drop of tumor cells can literally skip over normal tissue and implant lower down.
Which makes defining the target volume incredibly difficult. You draw your GTV on what you can see, but the actual cancer is already 2 centimeters south of that.
That's right. Surgical series suggest you may need 2 to 3 centimeters of craniocaudal margin just to capture that subclinical extension.
That is a huge margin. So when you put these 3 drivers together, late presentation, high distant mets, and this invisible spread, you get the survival statistics. 5-year overall survival for stage 4 is what, around 25%?
Around 25%. And the 10-year overall survival in that famous EORTC 204891 trial was only 13%.
13%. That's an incredibly humbling number. It means nearly 9 out of 10 patients eventually died from their disease or complications.
It's a very sobering reality.
So it leads us to the takeaway line for this section. If you're talking to an examiner or just reminding yourself while you're planning, you should say this: if I understage the extent or undertreat the neck, I lose the patient early.
That's the mindset. You have to be aggressive because the disease is so aggressive. Now let's translate that biology into our nodal defaults. We call these default 1 and default 2.
Okay, let's start with default 2. Bilateral neck on N.
This is pretty much non-negotiable for almost all cases. Elective nodal radiation is bilateral levels 2 through 4 by default.
I want to challenge that for a second. Let's say we have a patient with a small T2 tumor. It's clearly localized to the left piriform sinus. The right neck is clinically negative. Why can't I just treat the left neck and spare him the toxicity of bilateral radiation?
And that is the temptation, right? You want to spare the contralateral parotids, spare the constrictors, but you can't. The rich lymphatic network in that pharyngeal wall, it crosses the midline freely. Studies have shown that even well-lateralized piriform sinus tumors have a significant risk of contralateral failure. We're talking upwards of 20%.
And if you fail in the contralateral neck?
The salvage rates are dismal. It's
Yeah.
often considered an incurable recurrence. So the only scenario where you might, and I'm really emphasizing might, consider ipsilateral only treatment is a tiny, truly lateral piriform sinus tumor with an N0 neck. But even then, most major centers treat bilaterally because the cost of being wrong is just too high.
High stakes. So for us, and certainly for the boards, bilateral always. Okay, now let's talk about the risk ladder for nodal escalation. We start with bilateral 2 through 4. When do we add more levels?
If you have bulky upper neck disease, so N2B or higher or explicit level 2 involvement, you add level 5 bilaterally.
Okay, that makes sense. Posterior triangle coverage for a heavy burden. What if it's a post-cricoid tumor?
If it's post-cricoid, or if there's any esophageal extension at all, you add level 6. Those are the paratracheal nodes. They sit right in the tracheoesophageal groove.
And what if it's a posterior wall tumor?
If it's a posterior pharyngeal wall primary, or if you have bilateral nodes, you have to confirm high retropharyngeal node coverage. You want to make sure you're covering all the way up to the skull base.
Which brings us perfectly to default 1. Retropharyngeal nodes on N.
This is the critical distinction. I need everyone to listen closely here. Hypopharynx is not larynx. Larynx cancers, I'm talking true vocal cord cancers, they rarely need retropharyngeal node coverage because the lymphatics of the glottis just don't drain there.
But the hypopharynx.
But the hypopharynx defaults to retropharyngeal coverage.
Why is that?
Embryologically and anatomically, that pharyngeal mucosa drains superiorly to the Rouvier nodes. The data shows retropharyngeal involvement in 10 to 20% of cases overall, but that rate goes way up for posterior wall tumors or big T3, T4 tumors. A systematic review just last year confirmed this again.
So the board-safe rule is opt out, not opt in.
That's it exactly. You include the RPLN, which is level 7A, unless you have a specific, really defensible reason to omit them. For an uninvolved neck, you cover the RPLN to the bottom of C1. If the neck is involved, you cover to the skull base.
Okay, let's apply this to our case anchor. Our 58-year-old with a T3N2B left piriform sinus cancer.
Right. Let's map it out.
Yes.
Bilateral levels 2, 3, and 4 are mandatory. That's just our baseline. We add bilateral level 5. Why? Because he's got N2B disease-bulky nodes in the upper neck. He's already shown us that his cancer knows how to travel.
Sure.
We turn on retropharyngeal nodes bilaterally. Default is on Aaron, and we cover to the skull base superiorly because of that high nodal burden.
Check. What about level 6?
Level 6 is omitted in this specific case because the imaging showed no post-cricoid involvement and no esophageal extension yet.
Yeah.
But, and this is a huge but, if our workup showed that the apex was extending toward the cervical esophagus, we would add level 6 immediately, no question.
That is a lot of neck to treat. I mean, we are treating from the skull base all the way down to the clavicles.
It is, and that volume, it absolutely translates to toxicity, mucositis, dermatitis, dysphagia. But hypopharynx demands comprehensive coverage. The biology is just unforgiving.
And that leads us perfectly into default 3, inferior extent on N.
This is all about that cognitive error we mentioned earlier. The error of believing the scope shows you the bottom of the tumor.
So the first question heuristic.
Yeah.
When you sit down to plan a hypopharynx case, what's the first question you should ask yourself?
You have to ask, is there post-cricoid involvement or esophageal extension?
And if the answer is yes,
Then everything changes. You add level 6, you cover the superior cervical esophagus in your CTV. You even have to start considering whether the inferior extent needs coverage down to the thoracic inlet or the upper mediastinum. You might need to fuse a chest CT to your plan.
and what if the answer is NO?
If the answer is NO, you still do not trust that inferior edge. You plan generous inferior margins on your CTV. Remember those surgical series.
2 to 3 centimeters of submucosal spread.
Exactly. So you are saying even if the CT shows the tumor stops right at the cricoid, you're treating below that.
Absolutely. You cannot rely solely on the PET,
Right.
PET or the scope. The post-cricoid danger zone transitions directly into the esophagus. You really need an EGD to evaluate it properly.
Let's pause on that. The EGD, why isn't the flexible scope from the ENT clinic enough?
Because the flexible scope goes down the nose. It gives you a top-down view. But in a patient with a big tumor and all those pooling secretions, the scope often just stops at the top of the blockage.
It can't see how far down the tunnel the tumor actually goes.
Exactly. The EGD, the esophagogastroduodenoscopy, allows the gastroenterologist to actually push past the obstruction and measure the true bottom edge of that tumor.
Which moves us to the treatment paradigm, our default 4.
Default 4. Like failure risk is real. We have to talk about the fundamental question here. Surgery versus organ preservation. Historically, before the 90s, these patients just got a total laryngopharyngectomy.
Right. They lost their voice box, part of their pharynx. They'd end up with a permanent stoma and often a jejunal free flap to reconstruct the throat. It was effective for local control, but incredibly morbid.
Then came the organ preservation movement.
Mm-hmm. The landmark trial here is EORTC 24891, the Lefebvre trial. This is one of the Holy Scripture trials in radonts.
It is. What did they do?
This trial randomized patients with T2 to T4 piriform sinus or aryepiglottic fold tumors. Arm 1 was the gold standard at the time. Immediate surgery followed by post-op RT. Arm 2 was induction chemotherapy.
And that induction strategy was very specific. It wasn't just chemo, then radiation.
No, it was a selection strategy. Patients got chemotherapy first. If they had a complete response to induction, meaning the tumor just melted away, they proceeded to radiation alone.
But if they didn't?
If they had less than a complete response, they were sent to surgery.
So the chemo is kind of a litmus test.
Mm-hmm.
If the tumor is sensitive to chemo, it's probably sensitive to radiation, so we save the larynx. If it's resistant, we cut it out.
Precisely. And the results.
What do they find?
The result was equivalent survival. It was about 30% at 5 years for both arms. And about 2/3 of the survivors in that preservation arm got to keep their larynx.
Which was a huge win for quality of life.
Yeah.
You could survive just as long, but keep your voice.
Yes, but there's a really important expert insight here regarding that survival number.
Which is?
The insight is that preservation is a goal for the minority who survive. When the 5-year survival is only 30% and the 10-year survival is 13%, we're fighting a really difficult battle. The trial showed that organ preservation is safe, it doesn't compromise survival, but it didn't do anything to improve those dismal survival rates.
Then we have the Gore-Tech 2001 trial, which looked at the regimen.
Right, this compared induction regimens, TPF versus PF. So Taxotere, cisplatin, 5-FU versus just cisplatin and a 5-FU.
And the winner there was?
PPF. It yielded much higher larynx preservation rates, 70% versus 47%. So if you are doing induction, TPF is the standard.
However, for our case, and really for most modern practices, we're more likely to use concurrent chemoradiation instead of induction.
That's right. Induction has its own toxicity issues, particularly in older patients. Definitive concurrent chemoradiation, giving the chemo and radiation at the same time, is the standard for most locally advanced cases today. But that aggressive posture remains.
Right.
Because of the high distant METs and the poor overall survival, we default to comprehensive nodal coverage, generous margins, and systemic therapy.
And as you said before, do not confuse organ preservation with good prognosis. Just because we save the voice box doesn't mean we save the life.
Exactly.
So let's bring this all back to the clinical decision-making for our 58-year-old patient. We have the diagnosis, we have the map. What is the plan?
The recommendation is definitive concurrent chemoradiation.
Okay, let's walk through the logic, step by step.
Okay, point 1. He's T3 and to B. This is locally advanced, but his laryngeal function is preserved. His cords are moving. He's not T4A with cartilage invasion. If the cartilage were destroyed, that larynx would be non-functional and we'd lean towards surgery. But here, the organ still works.
Okay, point 2.
Point 2. He is a candidate for preservation based on EORTC 24891. We can offer him a chance to keep his voice without compromising his survival chances.
And point 3.
Point 3. Systemic therapy is absolutely essential. We need high-dose cisplatin, 100 milligrams per meter squared, given every 3 weeks. Why? Because of his N-to-B status and that 25% risk of distant metastases, we need systemic control. We're not just radiosensitizing. We are actively trying to kill micromets.
Okay, point 4 regarding the volumes.
We treat bilateral levels 2 through 5, plus the retropharyngeal nodes.
And point 5 regarding that inferior extent.
We need to be very careful. The scope had limited visualization, so I would order an MRI or a fine-cut CT and an EGD to confirm that inferior extent before I finalize those contours. I'm not starting treatment until I know for sure where the bottom of that tumor is.
Now, you have to talk to the patient. This is the counseling script. I'll play the doctor. You're the patient. You're scared. You can't swallow. Here's how I would deliver this really honest news. Mr. Patient, we've reviewed all your scans, and you have a cancer of the lower throat called the hypopharynx. It is an aggressive cancer, and it's a stage 4. We have 2 main options. We could do surgery to remove the voice box entirely, which would leave you with a permanent breathing hole in your neck. Or we can use chemotherapy and radiation together to try to cure the cancer while saving your voice box. Studies show the survival rate is the same with either approach. However, I need to be completely honest with you about the reality here. This is a tough fight. The survival rates are around 30 to 40% at 5 years. There's a real risk the cancer could spread to other parts of your body. The treatment itself is very toxic. You will almost certainly need a feeding tube because your throat will be too sore to swallow. You will lose weight. And you may have long-term swallowing issues, even if the cancer's gone. But I recommend the radiation chemotherapy approach because it gives you the best chance to cure the cancer while keeping your voice and your quality of life.
That is a tough conversation, but it's so necessary. You cannot sugarcoat hypopharynx. If you promise him an easy ride, he will lose all trust of you by week 3 of radiation when that mucositis really hits.
Speaking of toxicity, let's manage expectations. What are the acute effects?
You should expect confluent mucositis. Grade 3 is the expectation. The entire pharynx is being blasted, the constrictor muscles, the larynx, the base of tongue. It is all in the field.
Dysphagia.
It's going to get much worse before it gets better. The threshold for a prophylactic PEG, a feeding tube, is very low. In fact, many would argue for placing it up front. If he's already losing weight and struggling with liquids, he needs that tube now, before treatment even starts.
And weight loss.
Expect 10 to 15% total body weight loss, even with the tube. The metabolic demand of the cancer combined with the treatment is just enormous.
Okay, now let's talk about late effects. We call this the anchor for late toxicity.
The anchor is pharyngeal stenosis and chronic aspiration.
What drives this?
It's driven by that high dose to the pharyngeal constrictors combined with the chemotherapy. The muscles just aphid. They fibrosis and scar down, they become stiff, they can't propel food down properly.
And how does that present?
Progressive dysphagia, sometimes years after treatment. Silent aspiration, dependence on that PEG tube. The patient survives the cancer, but they're tethered to a feeding tube for the rest of their life.
And the counseling pearl here.
Use it or lose it. You have to tell the patient to keep swallowing during treatment, even when it hurts. Swallow water, swallow ice chips. They need to keep those muscles moving to prevent them from fusing shut.
And other late effects.
Hypothyroidism. Always check the TSH. The thyroid is wrapped around the airway, so it gets full dose. Laryngeal edema, chronic swelling of the voice box. Cartilage necrosis. It's rare, but it's devastating. And of course, xerostomia, dry mouth, although modern IMRT definitely helps spare the parotids.
Okay, we are moving into the final stretch. Let's do the board review. We have 3 oral board traps. These are the saves. The moments where you can really fail the exam if you're not careful.
Okay, trap 1. Omitting the RPLN because it looks like a lateralized tumor.
The examiner shows you a lateral piriform mass. You say bilateral 2 through 4, and then they ask, what about the retropharyngeals?
The save is, hypopharynx is not larynx. Retropharyngeal nodes are default. I include them. If you hesitate there, you look unsafe.
Trap 2. Trusting the endoscopic inferior extent.
The save is, I do not trust the scope. Submucosal spread is real. I will plan generous inferior margins and confirm with cross-sectional imaging or an EGD.
And trap 3. Offering preservation without discussing the prognosis or the distant Mets risk.
The save is to just be honest. I will counsel the patient that despite preservation, there is a 30% 5-year survival and a 25% distant failure rate. I will monitor closely for distant metastasis.
Let's do a quick recap of the board pearls.
Pearl 1. The 3 Ps, piriform, posterior, postcricoid.
Worst actor poor prognosis, high distant Mets.
RPLN default,
Bilateral neck, always.
inferior extent trap.
Postcricoid equals female plus iron.
Now for the board blitz. 3 rapid-fire questions to test your recall. Question 1. A 62-year-old male, T3N1, mobile cords. What's the treatment?
The answer is C. Definitive concurrent chemoradiation. The laryngeal function is preserved, so preservation is the standard. Surgery is reserved for salvage or a non-functional larynx.
Question 2. A 55-year-old female, postcricoid mass, iron deficiency. What is the unique nodal level?
The answer is C, level 6. The paratracheal nodes are required for postcricoid drainage.
And question 3. What is the truth about EOTC 24891?
The answer is D. Organ preservation yielded non-inferior survival compared to upfront surgery. It didn't improve survival, but importantly, it didn't worsen it either.
Excellent. We have covered a massive amount of ground today. We took a really deep look at the anatomy, the brutal biology, and the aggressive defaults you absolutely need to treat this disease.
We really have. Hypopharynx is intimidating, but if you respect the rules, if you respect these defaults, you can treat it safely and effectively.
So let's summarize one last time. We reviewed the 3 Ps, we reiterated the dismal prognosis statistics, and we hardwired the 4 defaults.
RPLM and on N.
Bilateral neck on N.
Inferior extent on N.
Failure risk is real.
And this sets the stage perfectly for what's coming next.
Exactly. In episode 32, we are going to operationalize these defaults. We will get into contouring, OARs, and planning walkthroughs. We'll talk about how to actually draw these volumes on the workstation.
We'll see you there.
Complete practice oral boards at radononsmartlearn.com and subscribe to Radon on Smart Review for our next episode. Thanks for tuning in.